Welcome to Podcast 4. We're going to talk about how to read plain x-rays of the shoulder and elbow. Refer back to this for small groups and when you get out into clinical settings. This podcast is going to address two things. By the end, you should be able to correlate osseous anatomy with radiographic landmarks in the shoulder and elbow. You should also be able to explain what features indicate normal on shoulder and elbow radiographs. Let's begin with the standard true AP of the glenohumeral joint. There are various ways to take an AP, but this is my personal favorite. So let's get our bearings here. First, these dark red lines show the cartilage or articular surfaces of the humeral head and glenoid. Up here, we find the AC joint. Next, the greater tuberosity, which sits laterally with relation to the humeral head on this view. Finally, let's mark the anatomic and surgical necks. In a normal shoulder, a line up the lateral border of the scapula along to the medial border of the humerus should be smooth, as shown here. We totally ripped off the Shenton line from the hip guys, but this is a nice, quick way to help establish normal relationships. We can also clearly see that the red lines of the articular surfaces are congruent and not overlapping. This is a normal radiograph. By way of contrast, let's look at these radiographs. In Figure A, we see a break in Shenton's line, and the articular surfaces are not congruent. This is an abnormal radiograph. This shoulder is anteriorly dislocated. In Figure B, Shenton's line isn't obviously affected, but the articular surfaces are not congruent. They're overlapping. This is an abnormal radiograph. This shoulder is posteriorly dislocated. So how do I tell anterior and posterior in a two-dimensional image? Well, stay tuned. This is a second standard view of the glenohumeral joint called the axillary view, as it is shot through the armpit of the patient. Here again, we have the articular surfaces of the glenoid and humerus. I've labeled anterior and posterior for you here, but if it's not identified, the coracoid is the key. It will point like a lighthouse in the anterior direction. Find it and you find your orientation. Often, the clavicle and acromion will overlay, as you can see here. The glenohumeral joint should look like a golf ball on its tee in this view. This is a normal radiograph. Despite it being critically important to obtain this view in times of injury, it is not standard in Calgary. It is also a tricky film to get in a sore patient, but there are solutions that you can learn. It is easily possible to miss a dislocated shoulder without this radiograph. This gives you your anterior and posterior directions of dislocation, and it's very robust against technique of taking the radiograph. So here are two axillary radiographs. Looking at A, we find our coracoid. Then we find our articular surfaces. This is an abnormal radiograph. The shoulder is dislocated in an anterior direction. Looking at B, same steps. Coracoid is here. Articular surfaces are here. This is an abnormal radiograph. This shoulder is dislocated posteriorly. Finally, the third standard view is a transscapular Y view or lateral view of the shoulder. Beginning with our basic landmarks, we see the articular surface of the glenoid head-on with the humeral head overlaid symmetrically. Next, our coracoid once again tells us the anterior direction, and you can really see the beak this time. The acromion forms the roof of the shoulder. Finally, the scapular body can be seen extending down the thorax. With the round humeral head centered on the glenoid and three spokes extending from that center, this reduced view is often called the Mercedes-Benz sign. This is a normal radiograph. The key to remember here is that by rotating the patient's trunk during this radiograph, you can make the shoulder joint look reduced or dislocated, and it's an unreliable radiograph on its own to exclude or diagnose a dislocation. All three of these films together are a complete basic set of shoulder radiographs. The final step before moving on here, when you're looking at an X-ray film of any body part, is to run your eye along the cortical bone looking for disruption in the smooth lines. This will give you clues about fractures. So well done. We're going to move on to the elbow. This is an AP radiograph of the elbow articulations. These are the key landmark features. The humeral articular surface consists of the curved surfaces of the capitellum laterally and the trochlea medially. On the radial head side, the articular surface is the dish that the capitellum sits in, while the ulnar surface is marked by the coronoid process. Note the nearly symmetrical amounts of space between the humerus and the radius ulna across the joint. The epicondyles are important landmarks for medial and lateral because the medial epicondyle is larger, and that helps you get your orientation. The extensor muscles originate laterally, the flexor pronators originate medially. This is a normal radiograph. This is a lateral radiograph of the elbow. Ability to make sense of this view depends on how well the technologists have been able to take it. The humerus should make an hourglass type shape, which represents the trochlea and medial joint surface, while the capitellum is a slightly larger roundness. The round tip of the humerus should sit symmetrically in the ulna, which we can see here. I've marked the coronoid and the olecranon processes that make up that articular surface on the ulna. Finally, the radial head and radius should sit centered on the capitellum. All of these conditions are achieved here, so this is a normal radiograph. Here we have a pair of elbow x-rays, a lateral and an AP. If we put our landmarks on, we can see that the round humeral articulations are not congruent with the ulnar surfaces. The radial head doesn't align with the capitellum. On the AP film, the articular surfaces are difficult to see on the radius and ulna, and certainly there is not a symmetric joint space or any congruency. This is an abnormal set of radiographs. This elbow has a fracture dislocation, and we'll see these films again in a later case. So we finished our crash course on reading shoulder and elbow x-rays. This will take lots of practice to get good at, but it's a skill worth cultivating if you envision yourself working in an urgent care, emergency room, or MSK-related setting.